Shoulder instability. Published by WordPress.com. Classifications. 1. Acute traumatic dislocation, TUBS. Anterior. Most common. Posterior. Often missed on initial presentation. Superior. Rare. Inferior. Luxatio erecta. 2. Recurrent instability. Recurrent microinstability may result in dead arm syndrome, instability, rotator cuff pathology, or nerve compression. 3. Multidirectional instability, ambry. Laxity in multiple directions. A. Etiology. 1. Traumatic, macrotrauma or repetitive microtrauma. 2. Non-traumatic, often associated with ligamentous laxity. B. Degree. 1. Dislocation, complete loss of contact. 2. Subluxation, partial loss of contact. C. Direction. 1. Unidirectional, anterior, posterior, superior, or inferior. 2. Bidirectional. And 3. Multidirectional. D. Onset. 1. Congenital, rare, associated with bony abnormalities or birth injuries. 2. Acquired, acute, chronic, or recurrent. E. Volition. 1. Voluntary, can be actively dislocated by the patient. 2. Involuntary, occurs without patient control. Traumatic unilateral Bankart lesion, TUBS, and shoulder instability. Introduction. TUBS refers to traumatic, unilateral, Bankart lesion resulting in shoulder instability, typically requiring surgery. Epidemiology. Shoulder dislocations account for 90% of shoulder injuries with a high recurrence rate, particularly in teenagers, 2% of the population. Common presentation, anterior shoulder instability. Pathophysiology and mechanism of injury. Indirect trauma. Fouche, fall on an outstretched hand, combined with abduction and external rotation. Direct trauma. Impact to the posterolateral aspect of the shoulder. Convulsions, uncommon cause of shoulder dislocation, posterior. Associated injuries. Labral and cartilage injuries. Bankart lesion, avulsion of antero-inferior labrum, Hagel, humeral avulsion of glenohumeral ligament, GLAD, glenoid labral articular defect, ALPSA, anterior labral periosteal sleeve avulsion. Fractures and bony defects, Hill-Sachs defect, posterosuperior humeral head chondral impaction, bony Bankart lesion, antero-inferior glenoid fracture, greater tuberosity fractures, GT, lesser tuberosity fractures, LT. Nerve injury. 5% incidence of axillary nerve neuropraxia and musculocutaneous nerve involvement. Rotator cuff tears. 80% in patients greater than 60 years and 30% in patients greater than 40 years. Multidirectional bilateral rehabilitation inferior capsular shift. CUS. Develops without a specific traumatic event, often due to generalized ligamentous laxity or repetitive overhead activities. Direction. Multidirectional instability, affecting two or more directions, anterior, posterior, inferior. Laterality. Frequently affects both shoulders, bilateral. Pathology. Characterized by capsular redundancy and laxity without a distinct labral tear. Treatment. Initial management focuses on physical therapy aimed at strengthening shoulder stabilizers. Surgery, such as an inferior capsular shift, is considered if conservative measures fail.